Sagnik?
All right. First of all, thank you so much for having me here. And first of all, it's a privilege, and I wasn't quite sure what to expect when Joe essentially convinced me that I should be here talking about something I actually care very deeply about. So I've been taking notes throughout the day, and essentially I can tell you at this point, whatever I was thinking of last night is completely out of the door. So I'm just making notes and trying to cover some of the highlights that I thought might be relevant, and I have some slides, and I'm going to blow past them pretty quickly. One thing as an observation, and Isaac and I, we were probably the first people from the healthcare tech vendor community who are up here. And I think from our standpoint, obviously we are not as close to the front line as many of you are. And we don't have a lot of the same experiences that you have. But what we sometimes are fortunate to have is a more broader exposure to many health systems and many providers across different states and different communities, et cetera. So that what it helps us kind of understand is get some pattern recognition of what's going on in different parts of the healthcare continuum in different states, et cetera. And so what I'm hoping is that we can bring some of that perspective into our comments as well. My goal here is twofold. One is to kind of give you a quick taste of some of the work that is going on in the care coordination platform community at large today. Some things that are a little bit more on the bleeding edge side of things. So the reason I'm here is I'm at a company called PatientPing. We are a care coordination platform. I'm not here to talk about PatientPing, but mostly to give you kind of a little bit of a primer on what's going on in the care coordination platform world today. And then number two, make the case that how implementing a scheduling system is an opportunity to really help accelerate the case for care coordination in the communities that we serve, and in this case, serving the veteran community. And as we do that, we've talked about care coordination a lot today, and I thought what might be helpful is to maybe talk a little bit about care coordinators and who are these care coordinators. And within all the health systems that I've worked with over the course of the last 15, 16 years, they've taken different forms. They have care managers, there are case managers, there are navigators, there are people with the title care coordinator, or social workers. So there's like a broad swath of people out there who are trying to be in the patient's corner and trying to advocate and trying to care for that patient. And I'm kind of differentiating them from caregiver a little bit, because these people are typically part of the delivery system versus someone who is related to the patient. But this is an increasing population. And in fact, the broad role of a care manager is one of the hottest job titles out there. And there's there's probably I don't have firm numbers for this, but anecdotally I've heard that there's more than 2x the number of care managers out there today than were 5 years ago, and most health systems are investing more and more in these. And so with care coordinators, again, the broad definition I would use is someone on the delivery system side who is acting on behalf of the patients. Now, in that kind of a setting, I had my minor interoperability story. So full disclosure, I've been at PatientPing for 6 months. Before that, and for 16 years, I used to live in Wisconsin. I was actually at Epic. When I first moved to Boston, we moved our family. I have an 8-year-old daughter. We were trying to get her admitted to a public school. Newton public schools in Boston are kind of very much, they're a bit of a stickler for some things, and they wanted an immunization report. We got it off of the provider that we used to use in Wisconsin and printed it out and gave it to them. And then 3 days later, we get a call, there's a problem. Your daughter does not have all the immunizations that she needs. And we're like, wait a second, we are not one of those types of people. What just happened here? So it turns out that during the 8 years of my daughter's life, for 1 year we had switched providers, and one of the immunization was in another provider's system. Now, how does this come back to care coordinators? The district school nurse was really helpful. She actually volunteered. Okay, yeah, I understand. I didn't tell her that I was used to work at Epic. But she was like, okay, I'll help you figure out this problem. And she was very helpful. She actually called around and actually helped get the missing immunization records from this one provider that we happened to have gone with for 1 year. So that's kind of that's the kind of experience that as a patient when you have with the system. This was a school nurse. This was not someone who's managing someone who is like acutely ill or has severe needs. But the care coordinators, in my mind, they're like some of the unsung champions of the health systems today. We've talked a lot about providers and physicians and nurses, but there is this whole swath of a healthcare ecosystem that are not quite, I'd say, we haven't talked about that enough. And what I'm hoping is, as we talk about care coordination, we keep them in mind. So with that, let me quickly go past. So PatientPing is a platform that, again, tries to connect providers across different parts of the healthcare continuum, different health systems, different EHRs, and kind of bring them together so that we do two things. So again, forget about PatientPing, but when a care transition happens, there are three people who are involved. One, obviously, there is a patient. Then there is the provider or the provider team who's treating the patient that's in front of them. But then there are all of the people who have a vested interest in the patient's care, which could be these care coordinators. In some cases, in the more commercial sector, it could be the payer, or it could be the PCP's office if they're in a medical home model. So in those moments when a patient is having a care transition are those moments that people could intervene. Now, obviously, the providers who are treating the patients will intervene, but the providers who are not with the patient, if they knew in real time where the patient was, that gives them that moment to intervene. So I'm going to skip past that. So when a patient shows up in the ED, no matter which ED, it could be a VA ED, it could be a community ED, it could be in some critical care hospitals ED. If there was a technology that could let that care coordinator know in real time, not as in like a batch message the next day, but in a matter of minutes that the patient is in an ED and the patient's in a vulnerable state, maybe they presented with some serious mental illness diagnosis, or maybe it's just that they're homeless, but now they're in the ED, and now is the time to intervene, catch them while they're there and intervene. That's an opportunity. Not only that, there's all of the extended care teams, some of whom who have some financial risk associated with that patient or an actual care relationship with the patient. If they knew that the patient something was happening with the patient, it's an opportunity to coordinate care. And this does not have to wait, and actually I would say cannot wait until the patient shows up inside of the hospital or the health system the next time. It has to be in the moment, otherwise you're going to lose them. So that's what some of the newer care coordination platforms do, is how do you activate those care teams in real time when something is happening with the patient. And there's the care coordinators can be in all kinds of different shapes and forms. How do we do that? So the technological underpinnings for this is something super simple. Again, this is getting into the details of this a little bit. HL7 ADT fee. So these are these admission, discharge, and transfer notifications that any EHR for the last 20 years has been able to produce. And again, I'm going to be a little provocative and say, this does not need new technology or even FHIR. FHIR has a very important role to play, and I'm sure it's going to make a lot of difference in the coming future. But there is a lot of technology that is already out there that can be activated with the right set of workflows, right set of business use cases, and right enabling platforms to help enable care coordination for those patients. When Joe kind of talked about the levels of hierarchy of interoperability, I would argue that we are already there at least for these types of care coordination use cases, on the technical side, on the semantic side, and on the syntactic side. What it needs is kind of that organizational kind of business case in order to kind of bring it all together and help enable care coordination. Who is the person who's going to react when something happens to this patient if we do notify them? Who's going to call up the ED and help them arrange a care transition for that patient? So those are the questions that we need to answer. So that's kind of the part one of what I wanted to make the case for is, number one, that there's technology that is available today in the market. Many organizations use it. I've kind of blew past the slide with the map with the dots. So that's kind of just like the organizations that are using these types of things. Atrius uses, is very sophisticated in their care coordination efforts. They use a platform like this to inform when something is happening with one of their patients and act in real time. So that was number one. Now, that works really well for acute care transitions when the patient's in the ED, in the hospital, in a post-acute setting, whether it's a skilled nursing home or whether it's a home health aide visiting them. We still have a problem, which is a lot of the care coordination handoff failures happen when the patient transitions from an acute to an outpatient setting. And in many cases, when the patient is transitioning from a primary care to a specialty setting. So what does that lead to? This is obviously, you all know about this. There's pretty well-studied and well-published evidence out there on how a post-discharge follow-up visit not happening leads to a higher incidence of readmission, or a med-rec not happening post-discharge leads to higher readmission. So there's a lot of opportunities for improvement if only we could get a better handle on the acute to outpatient care transitions. And this is, I think, where a lot of the opportunity comes in. So there's solutions out there today that are solving the acute care transitions, and today, like PatientPing is doing something. There's going to be Care Equality, Commonwealth, and a lot of the other groups are going to start doing more and more work around this. So this is a problem that is starting to get solved more widely on a market level. But there's a lot of blind spots in the care continuum today. A lot of the interoperability efforts that are really reshaping the industry in many ways are really tailored around what happens when the patient shows up at your front door. When the patient checks into your outpatient clinic, you can pull their records from the systems that are connected, whether it's within your own system or through Care Equality. But what doesn't happen as well is, how do we let that social worker know that one of the patients that they're managing showed up at at an urgent care center, or showed up at some sort of showed up at a cardiologist practice because their care plan kind of led them elsewhere. So there's a lot of that I'd say blind spots in the care continuum that we could help fill and help enable better care coordination. And what are some of the use cases that if that information could help drive? I just put a few of these out there that we have heard from many of the health systems that we have talked to. Maternal mortality, just following a for prepartum care regimen shows that essentially that has a much bigger impact on maternal mortality rates than postpartum care. So if before the patient first hits the hospital, if we could make sure that the care coordinator was alerted anytime the patients were missing their visits, that's an opportunity. And that's something that can be enabled if we had visibility into what kind of outpatient care the patient was getting. Reducing readmission risk we talked about. The last one, for example, a patient missing their dialysis appointments, dialysis appointments, infusion for chemo, those are all, that's care that is delivered in the outpatient setting. And if there was visibility that a patient missing successive dialysis appointment, that's almost a guarantee that this patient is going to show up in the ED. So how can we capture that ahead of time and intervene so that an adverse event can be prevented? So there's a lot of opportunity there. And this is just a few of these use cases, but the thing that can help enable these use cases, just taking that analog for those acute transitions, which was the ADT feeds that are fairly prevalent today, is the similar version of that, which is the HL7 scheduling feeds or SIU feeds, to using the more specific terminology there. And notice that I didn't put FHIR in there. FHIR will help. FHIR is going to revolutionize a lot of things in the coming years. But my argument would be, we can get started now on the technology side, and on the left-hand side on the ADT feed, some of you might be following some of the rulemaking that's going on CMS, which is, I think, part of the CMS interoperability proposed rule. They're asking for all hospitals to share their ADT feeds, and this is precisely to drive those care coordination workflows that I talked about. Within the VA, because this is an opportunity, like with the VA, the kind of the levers that you have and the size of the populations that you manage, if you could make those scheduling feeds be available for the purpose of care coordination, you'll be able to address a lot of those use cases that we talked about. And guess what? This will, I guarantee you, I'm speaking for my Cerner friends here, I'm pretty sure a Cerner can produce an HL7 scheduling feed. And I'm sure Cerner has been able to do that for a long time. So it's not a technology limitation. And I think if we are able to open that data up, a lot of good things will happen on the care coordination side. So thank you.
Thank you, Sagnik. You're going to get a couple questions, I'm sure, as you're popping up. But I think that to underscore the point that you made there around even thinking about SIU, right, and what the rest of the healthcare ecosystem is going to start to do, and being sure that the VA systems in the future can take advantage of that for the benefit of the veterans, particularly if care is going to be starting to deliver on the outside. I think understanding that and making sure it's forward compatible becomes, again, very, very important. So
Lisa Lehman again from Vision One, Chief Medical Officer. So thanks so much for your work in this area and your presentation. It's extremely exciting, and I want to, I guess, underscore how critical this kind of technology is in the era of the Mission Act, where we have to, in order to really keep our veterans within the VA healthcare system, we need to understand and be able to track where they're going out. And we've talked about in our vision embedding a VA person in a community hospital so that they can be redirected back to our healthcare system after hours. And so I think that this kind of technology is really critical. And at the same time, as someone with a background in ethics, and knowing the VA's very stringent approach to data security and privacy, I'm curious how you overcome those issues to really allow us to leverage this technology within our own healthcare system.
Sure. So with any kind of patient information, security, privacy is number one key and paramount. And any enabling technology has to kind of check all of the right boxes to make sure that that's kept up to date. There's another piece to that, which is patient consent and handling of sensitive information. So that's kind of also going to be any kind of care coordination platform needs to make sure that all patient consent related requirements are met, as well as for certain types of sensitive information such as substance abuse information, etc. There are some very specific rules around that. Those have to be respected. So not sure I'm fully answering your question.
Well, so I'm curious if this has been explored in the context of VA regulations and data, more specifically, whether it's really feasible. And, when you talk about consenting, are you suggesting that in order to share these kinds of feeds and to develop this technology within our healthcare system, you would need patient consent from every single patient? We're talking about, as we heard this morning, we have 9 million veterans and 6 million who are enrolled and 6 million who are using it. So that's a huge feat to accomplish, but I don't even have clarity on how you're doing this in other healthcare systems.
So I shouldn't speak for the VA's consent requirements because I'm certainly not an expert on. Actually, I don't know much about that at all. Usually, for consent, most places would be have an opt-out model. And that's how all of the interoperability that's happening today via care equality, etc. They follow those kind of same operating models. So this would not be any different than that. And I don't know if there is anyone who can speak to.
I think Robert may be able to get to that because this is a lot of what the HIEs face, right, in terms of exchange. I know Massachusetts has flipped from an opt-out to an opt-in model and trying to figure out how to get that information flowing a little bit better.
So that's unfortunate, and I can't figure out. There we go. Unfortunately, it is one of the issues that health information exchange has to deal with on a regular basis. So the exchange of health information for patient treatment purposes and some other HIPAA-allowed purposes for use is allowed under HIPAA without patient consent. What the HITECH Act did is require organizations to allow patients to opt out of the electronic exchange of health information, and didn't call out the specifics of how that needed to be provided to them. In California, if you'd look back probably half a dozen years ago, I would say probably half of the organizations in California that were sharing electronic information were opt-in organizations and half of them were opt-out. That means that you either had to affirmatively assert, yes, you may exchange my information as opt-in, or no, you may not exchange my information as opt-out. They have all, without exception, converted over to an opt-out model. California state law is actually silent on the matter, so it's all done as local policy. And then the exchange mechanism relies on the disclosing organization following their policies and the wishes of the patient in their decisions to disclose. So it's not an unconvoluted model, but there are examples of organizations that have gone through that. Now that ignores 42 CFR Part 2 requirements, different animal that I think a lot of organizations are still working through, but one of the things that I would point to is that California put together out of the Office of Health Information Integrity an interpretation of federal and state law on the disclosure of sensitive information. It's a 172-page document that talks about what the requirements are for exchanging sensitive information. It's not a bad reference of at least one government organization's interpretation of federal and state law.
Thank you, Robert. As you're coming up, why don't we let Don ask a question to Sagnik?
Very quick practical question. So you showed the diagram, which I think wasn't labeled, but looked like a home. And if you want to know where your patients or people are, they're sitting in their home. And with patients who are complex, with a lot of needs, a lot of effort's gone in by some organizations to really touch them in their home and deliver the kinds of services and community help they need. That's often kind of neglected in these models. I'm wondering, so you take the Camden Coalition, which Jeff Brenner is now, I guess, at United, founded, and I look at their data platform, which was custom-made for their nurse-driven community health model. Is that just going to go away? You're going to co-opt it? You're going to incorporate their features? Because I don't quite see that yet in what you said.
No, I think that's a great question. So, there are going to be systems of record, and there's going to be information about those patients that we think will reside in many cases within the EHR, but then there will be some additional and auxiliary data sources that will, like, I'm not that familiar with the Camden Coalition's database, but that might also have some additional information. I think the one thing that we're starting to see happen is instead there are certain things that by nature need to be deep. EHRs need to be deep because they handle a lot of workflows. They have a lot more information about the patient. Then there are other things that are more horizontal, that are mostly about making connections between places. And those things will not have necessarily all of the information, but those things are those platforms essentially are meant to create those connections, and then the connections will help enable the access to the broader depth of information that exists in each of those places. Could be the EHRs or could be other databases, but fundamentally, if you first know where that information lives, then it opens up that next level of care coordination, which is now let's talk and exchange information. Initially, it could just be human beings talking to each other, but then eventually electronically exchanging information as well.
Thank you.